Some reminders and announcements. Exam 1 posts today on Monday. It's due on Sunday at 11 p.m. You'll have 90 minutes to complete the exam. So from the time that that you open the exam, you have 90 minutes to complete. You can't close it and then come back to it later. The exam will have a format very similar to the homework. It includes multiple choice questions, true, false, and free response questions. And I recommend focusing on studying the lecture material. I pulled most of the exam material from the lectures. And please do remember that there's information that's on the lectures that is not in the book. You are absolutely able to use the book, the lecture PowerPoints, and your own notes on this exam, but you can't work with other people on the exam, especially not other students. You need to do it by yourself. And please note that homework 5 is due Sunday at 11 p.m. as well. So be careful with your time on Sunday. Okay, Chapter 4, Research in Clinical Psychology. So the purpose of research in clinical psychology, and I suppose research in general, but it allows individuals to discover things for themselves rather than just relying on the knowledge of other people. So if you have a question about some phenomena in clinical psychology, if you're a researcher, you can design a study and try to answer that question. It helps avoid speculation, misconception, and biased beliefs. So before clinical psychology research was a thing, a lot of people just had a lot of assumptions about how the human mind worked. Psychology is a relatively young science in general, although it's kind of been embedded in other areas such as philosophy and literature for a long time, but as a science that's recognized by itself, it hasn't been around that long. And there's been a lot of speculation and wrong ideas about how the human mind works and about human behavior. And research is a really powerful way to clear those misconceptions. As well, it provides a way for researchers to refute, extend, or modify existing theories. And this is really where the bulk of research happens. Most research is not seminal work that really changes the field. Most research adds incremental bits of information to pre-existing body of knowledge. I'll talk briefly about my own research just to demonstrate one line of research that might be pursued by somebody in clinical psychology. So one of my main projects right now, my dissertation project, is looking at the association between trauma and inhibitory control in people with first episode psychosis in South Africa. And that sounds like a very specific research question, and it is. And actually within that I have about 5 different research questions. So kind of jumping back to what I was saying earlier about a lot of the research in clinical psychology and a lot of research in general in many fields is really incremental. You're adding hopefully adding a small piece of information to the existing body of knowledge in the field. And it's not likely to be groundbreaking, but it's kind of one more piece of the puzzle. So in my case, one more piece of the puzzle of understanding psychosis or schizophrenia, especially in international populations, especially in low resource settings. So I've kind of just added some images that are associated with this project. You don't have to understand them, but essentially I'm using structural and functional brain images of some individuals with early psychosis in South Africa that are collected in the South African sample, and looking at whether childhood trauma and inhibitory control, or this ability to inhibit or stop behavioral responses, is associated with psychosis symptoms. So there's sort of this theory that early childhood trauma, traumatic experiences when somebody is young, makes changes to the brain that impairs people's ability to properly inhibit behavioral responses, or at least in part contributes to this. And then these brain changes as well contribute to the development of schizophrenia. So again, just an example of one type of research that somebody with clinical psychology, in clinical psychology might do. This is another example, and this is the research of a friend of mine. His name is Jamal Asaili. He's a professor now in University of Pennsylvania Hershey, but he was at University of Hawaii as a graduate student. And he did a lot of work on body image in people with eating disorders. So we worked in a clinic here in University of Hawaii, and in this clinic they specialized in treating people with anorexia and bulimia and other eating disorders. And Jamal was really interested in body mass index and whether these labels of body mass index were affecting people's self-image. And so I think most of you are probably familiar, but body mass index is sort of this rough estimate of how much fat there is in the body. And it's usually calculated by comparing somebody's weight against their height, which is a really rough and kind of not very accurate measure of body mass index. And so there are these categories. If you're between 25 to 30 BMI, then you're overweight, and ideal is a 19 to 25, under 19 is underweight. And I think these vary from male and female, so these might be the female categories. So Jamal and a number of other people in the eating disorder field have noticed that BMI is not really appropriate for individual diagnoses. Despite this, a low BMI is required for a diagnosis of anorexia nervosa. However, at least the way that we measure BMI in most cases is through this proportion of weight and height, which is rather inaccurate. So it doesn't accurately measure weight from fat versus lean muscle mass. Somebody who has a lot of muscle might be heavy, but not actually unfit. Doesn't account for the size of somebody's body frame. As well, BMI labels were intended to be used in a medical setting just to help people stay within a healthy range of body fat, but they've become maybe stigmatizing if somebody's considered obese based on the level, but based on the categories, this could be rather stigmatizing. The cutoff scores are largely arbitrary. They're not necessarily based in any research, and the BMI labels don't really predict health and mortality, at least as well as they purport to. And this is a really nice example, I think, that Jamal provided about how well we can predict BMI categories. So here we have 4 ladies who seem to be somewhere, at least visually, they seem to be somewhere in the same range of body mass, and they all seem, at least as we look at them, to be relatively healthy individuals. However, based on this, the first woman would be considered underweight, the second would be a normal weight, the third would be overweight, which seems surprising, and the fourth would be obese. And looking at this individual, she just doesn't look obese. It doesn't seem to be an accurate label for her weight. So if you had to guess, what do you think your BMI label would be? So let's say that you think you go into the doctor and you think that your weight label is a normal weight. You've always been somebody who's a normal weight. You exercise semi-regularly. But your doctor tells you that you're overweight. What does this mean? And some of the questions that Jamal has come up with related to this phenomenon of BMI is, are you less satisfied with your body now that there's this somewhat arbitrary label of overweight, and as stigmatizing label as well? Do you perceive yourself as being heavier as you did before this doctor labeled you as overweight? And are you considering going on a diet or changing your day-to-day behavior because of this label? and Jamal underscores that nothing is really changed except the weight label. Your height and weight remain the same as they were before the doctor said you're overweight. So from this, Jamal generated a research question: can BMI labels such as normal weight and overweight affect our body image, self-image, behavior, etc., independent of our actual weight and shape? And this question is about sort of normative ideas of body image and the processes by which somebody develops a poor body image. So a side interest of Jamal, because he's a eating disorder researcher, is body image in the normative population and how sort of a dysregulation of somebody's body image might lead to disordered eating. So I'm going to give you another example. We'll return later to the BMI example. For now, I just wanted to set the stage. When we talk about the different types of designs of research, we're going to return to that example about BMI. But for now, I want to give you one more example of a type of research that somebody in clinical psychology might do. And again, it's an example from Jamal because he does do research that's more directly linked to his clinical work. So he studies eating disorders, as I mentioned, and an eating disorder, I think most of you are familiar, but it's disturbance of eating or eating-related behavior that results in altered consumption or absorption of food. So somebody might consume food, but then throw it up or use other means to eliminate the food. And eating disorder significantly impairs physical health or psychosocial functioning. Examples include anorexia nervosa, bulimia nervosa, binge eating disorder, other specified eating disorders, and unspecified eating disorders. Anorexia nervosa is one of the eating disorders that most people are familiar with. A couple criteria are necessary for diagnosis, so restriction of energy intake relative to energy requirements, leading to a significantly low body weight, so taking in fewer calories than is needed for normal body functioning, as well as an intense fear of gaining weight or becoming fat, persistent behavior that interferes with weight gain, even though this person is at a significantly low weight, as well as a disturbance in the way that one's body weight or shape is experienced. So undue influence of the body weight or shape on self-evaluation, somebody's self-image being really wrapped up in their body weight and in maintaining a very low body weight, or a persistent lack of recognition of the seriousness of the current low body weight. So this kind of ties into something we talked about in previous chapters, where in some mental disorders, distress is not required for the diagnosis of a mental disorder. And this is sometimes the case in anorexia nervosa, that somebody has this low body weight and kind of these maladaptive ideas about low body weight being extremely important. And they may also, or often also, have the sense or the idea that this is not a problem and don't believe that this is causing them distress. Another example of an eating disorder is bulimia nervosa, which a lot of people are also familiar with. This is characterized by recurrent episodes of binge eating. So someone eats a large amount of food, huge amount of food, in a discrete period of time, so usually in a short period of time, and there's a sense of no control over eating during this episode, like feeling like they can't stop eating or control how much they're eating. As well, in bulimia nervosa, there's recurrent inappropriate compensatory behaviors to prevent weight gain from the intake. So they might throw up, use laxatives or diuretics or other medications. They may fast for long periods of time afterward, or exercise excessively to try to prevent weight gain based on the binging. The binge eating and compensatory behaviors have to occur at a certain frequency, so at least once a week for 3 months. And again, as is the case in anorexia and most eating disorders, self-evaluation has to be unduly influenced by body weight and shape. So somebody has to, their body weight, somebody's the shape and the weight of their body has to play largely into their own self-image and their idea of their own self-worth. So cognitive behavioral therapy, which we're going to discuss in more detail in a later lecture, is the treatment of choice for eating disorders based off of research, previous research. However, CBT fails to eliminate binge eating and purging in approximately 50 to 70% of individuals with bulimia, and has even worse outcomes for anorexia nervosa. So this is the best treatment we have, but it's the most research-supported treatment that we have, but it's still not working in the majority of individuals. So more research is needed for new treatment approaches for eating disorders. So this is what we would call in clinical psychology like treatment research. You're looking directly at a type of intervention, a treatment for a psychological problem. Food phobia is the anxiety or expressed dislike or behavioral avoidance of certain foods. So, for example, people with eating disorders might avoid fried foods. Also a fear of modifying dietary rules and rituals. So people with eating disorders often have very ritualistic behavior associated with food and kind of like strict rules. They don't eat after 7 p.m., they don't eat yellow foods, things like this. Fear and avoidance of food and weight-related situations. So eating non-diet foods with someone who is on a diet might be very fear-inducing. And then exposure is proposed in this study as a treatment to reduce fear, anxiety, and avoidance. So the proposed treatment that Jamal and his colleagues were suggesting was something that's called exposure. Exposure is something we do with people with anxiety often, where if somebody fears a specific thing, so if you fear dogs, for example, you would gradually increase your exposure to dogs until that fear is overcome, to say it in simple terms. And it's a common strategy for dealing with anxiety. And in this case, Jamal and his colleagues proposed addressing the sort of fear avoidance, the avoidant behavior, and the sort of fear of food and fear of certain food situations. In eating disorders, they approach that like it was almost like a phobia. And so they used exposure to address the food phobia in eating disorders. And in exposure therapy, you kind of have these exposure sessions, which are guided by a therapist. And in a beginner exposure session with somebody with an eating disorder or like a kind of food phobia, the patient gets a dessert that is maybe a little less calorically dense, so a sherbet. And then the dessert for the therapist is this sort of elaborate, very sugary, calorically dense sundae. So the patient's starting kind of like with an easier exposure stimulus. In an intermediate exposure session, so this might happen later in exposure once the patient's able to eat the sherbet without too much distress. The exposure stimuli are switched, so the patient will eat the dessert that's more calorically dense, and the therapist is eating the sherbet. And this is important for two reasons. One, the patient is eating a dessert that's a little more fear-inducing. It's more likely to make them gain weight, which is their fear. As well, people with eating disorders are often comparing themselves against the people that they're eating with, and so it might be additionally distressing for them to eat something that is calorically dense when somebody at the table is eating something that's less calorically dense. And then in the advanced exposure session, a very scary situation, a very fear-inducing and uncomfortable situation for someone who suffers from an eating disorder would be that the patient is eating this calorically dense dessert, and the therapist is eating nothing. So this kind of is building on the previous situation where the patient is comparing themselves to the therapist. And this would be presumably very distressful for someone with an eating disorder. And so the idea is that they are sort of facing their fear of eating food that could lead to weight loss, and the fear of eating this food in the presence of someone who is not eating that food. So just to sum up for that example, the research question that Jamal and his colleagues addressed was, does exposure treatment help reduce the fear, anxiety, and avoidance of food in patients with eating disorders? And I don't have his results. I'm not certain that they've written them up yet, but essentially they did find that it was helpful in reducing some of the feared eating behaviors and feared food stimuli in people with eating disorders, and this has been found in other studies as well. So I thought that was a very nice example that Jamal and his colleagues had of research that very directly informs our work in clinical psychology. Okay, jumping into research methods, and this is material from your book. So there's observational methods. And if you've taken research methods, I think it's 225 course, a lot of this is probably going to be review. But in observational methods, there are a range of observational methods, including unsystematic, naturalistic, controlled, and then case study. In unsystematic observation, this is very basic and casual observation. So it's planned, but it's not restricted. But it does help us to develop testable hypotheses. So for example, from the previous example of that research, the clinician who's doing the exposure therapy, the exposure sessions with the desserts, may kind of have an unplanned observation of a patient's abnormal response to that dessert. Witnessing that behavior can lead to a greater understanding of the patient's issues. So somebody might have been for example, when Jamal and his colleagues were conceptualizing this study, looking at exposure therapy to desserts in people with eating disorders, it might have been because during therapy they noticed that a patient had sort of a fearful response toward desserts. So it does help in developing testable hypotheses, but we must be extremely careful not to make too strong of conclusions from unsystematic observational research, because it is sort of just things that we coincidentally observe. Naturalistic observation is observation that is carried out in real life, but it's carefully planned, and the observer is not in control of the situation. So certainly more rigorous and systematic. It's pre-planned, but you're not controlling the situation, limited in scope, and also can be very helpful in generating hypotheses for even more controlled studies. So for example, a trained observer, so someone who understands the phenomenon that they're observing, might watch children on a playground, noticing the relationship between aggressive behavior and friendship, and might generate a research question kind of about childhood behavior and friendship from this. In a controlled observation study, the observer has even more control over the situation, or exerts more control over the situation. It can still occur in a natural setting or a clinic, like a clinic or a research setting, but the observer establishes the situation that's being observed. For example, if a researcher is interested in children's interactions and how they develop friendships, they can ask the children or the children's parents if they can participate in a research study where they're going to observe children in the playground setting, but they've asked the children to try to create friendships with each other, and then observing how children go about creating these friendships. So you've kind of introduced the variable or the phenomena that you want to observe, which is how kids create friendships. This is relatively cost effective, as is most observational research. It's relatively cost effective compared to some of the other forms of research that we're going to talk about later, like experimental work. And it can help gain more clinical insight into the nature of the problem. So it's kind of one step beyond just generating research hypotheses. You're actually kind of getting to the meat of answering a research question. Case study is the intensive study of a patient in treatment. So you're studying one individual. In observation research, you are a little more likely to be studying multiple individuals. You can study just one individual, and it's more hands-off. But in a case study, it's you're dealing with one person, and you are kind of picking apart sort of like every aspect of that individual's functioning. So this often happens when somebody presents at a clinic with a sort of unique presentation, a unique clinical presentation. A lot of times when dissociative identity disorder, which used to be known as multiple personality disorder, this is kind of like one of the only ways that this has been studied because it's such a rare occurrence. In fact, many people don't believe that dissociative identity disorder is a real thing. Many very skilled clinicians believe this, and I am actually not sure if I believe it either. But research on dissociative identity disorder has been mostly case studies because it's such a rare phenomenon. Experimental studies are not possible. You can't get a group of people with dissociative identity disorder together. So in this case study, you would kind of study everything about the individual, their detailed history, childhood history. You would probably do a lot of assessments about the personality functioning and other psychopathology that they're dealing with. This can also be used to kind of set the groundwork for other scientific investigation. So if there's a phenomenon you're interested in studying, but you kind of want to get more information about what aspects of the phenomenon you want to study, case studies can also be really helpful. So they lack universal scope. You're only looking at one person. You can't make cause and effect conclusions. You can't say because this person, this one individual was traumatized during childhood trauma causes dissociative identity disorder. You would need a lot more people with that same history to make that conclusion, or even, to make that conclusion. As I mentioned before, it can be kind of like a prelude to further investigation. So there are also, on a grander scale, epidemiological methods. So we're kind of going from case studies, which is small, micro, individual studies, to epidemiology, which is a study of incidence, prevalence, and distribution of an illness or disease in a given population. So you're looking at a whole population and saying, how often does this occur? Where does this occur within this population, etc. And this is almost invariably survey and interview based. So a lot of times epidemiological studies will take place in countries that have socialized healthcare, because there is information on anyone who's engaged in the healthcare system. There are certain questionnaires, certain aspects, some demographic data that is provided as part of engagement with the healthcare system, and this can later be used to study the epidemiology of certain disorders and issues. So using epidemiological methods, you can study the incidence of a disease or a disorder, especially that develops within a given time. So using some of Jamal's work as an example, the incidence of bulimia has increased over time since the 1950s, though it may be leveling off right now. So there's an observation that this has become more common since in the past 70 years. You can study prevalence, so the overall rate of cases, new or old, within a given period of time. So for example, you can notice that the lifetime prevalence of bulimia among women is 1.5%, among men it's 0.5%. You can also look at risk factors, a risk factor being a variable that increases a person's risk of experiencing a particular disease or disorder over their lifetime. So if we wanted to go back to that first example of BMI, we could study the incidence. If we had a lot of data on a lot of people experiencing body dissatisfaction, we could notice if we had kind of like longitudinal data, so if we had data over time, we could look at how body dissatisfaction in some individuals can lead to later development. It can be a risk factor for later development of anorexia or bulimia or other eating disorders. In correlational method, you're looking at the relationship between two variables. We use a statistical test called Pearson correlation coefficient, which is symbolized by R. And in Pearson's correlation coefficient, a positive value up to 1 indicates a perfect positive relationship, meaning for every like 1 unit that one of the variables goes up, the other variable goes up by 1 unit. So this essentially never happens. It means you're measuring that both your variables are measuring the same thing. Perfect negative relationship would indicate that your variables are measuring absolute opposite things. So again, this never happens. It would mean that for every unit that one of your variables goes up, the other variable goes down. And then a 0 is no relationship. And this is represented by scatter plots. It's a visual representation. So in these scatter plots below, each of these little dots is like a data point. And in a positive correlation, you can see that it's not a perfect 1-to-1 relationship. It would probably be like a 0.8 relationship in that positive correlation. Same with the negative correlation, that would probably be like a negative 0.8. And then in the no correlation, that would be like a 0. Here's an example of hypothetical data for the correlation between anxiety and a measure of control. So people with anxiety often feel the need to exert a lot of control or want to have a lot of control. And for all these individual subjects, we have their anxiety score and their control score, and we can see that there's a positive relationship in the scatter plot between the control score and the anxiety score. So it's a positive relationship, and it's those dots are like sort of close together. So the R, if we ran the statistical test, the R would be a positive value, and here they came up with the value of 0.76. Really important to note that correlation does not mean causation. So just because two variables are correlated, we can't assume that there's a causal relationship between them, that one variable causes the other. There's this classic example, or a version of a classic example, that it was observed in some city somewhere that the more the incidence of ice cream being sold, so the more like ice cream cones that were sold, the more shark attacks there were. And so you wouldn't, so the kind of like wrong conclusion that you would infer from this is that ice cream, the consumption of ice cream causes shark attacks, which is, there's no evidence for this. There's a realization of like the third variable problem, which is that both ice cream sold and shark attacks are associated with warmer temperatures. So the warmer the temperatures, the more ice cream that's sold, and the more people are out in the ocean, meaning there are more shark attacks. So you can see from this example, it's really important not to assume that just because two variables are associated, that there's a causal relationship between those variables. There may be some kind of third variable that's sort of driving that relationship. Another really nice example that I'm pulling from Jamal's work again is there's a correlation between body dissatisfaction and eating disorder pathology, but just because there's a correlation doesn't mean that body dissatisfaction is necessarily causing eating disorders. It's possible that that both of these variables are associated with low self-esteem, and that's actually the link between them. possible. It's also important to note that even if there is a causal relationship, even if we know from other experiments that there is a causal relationship between two variables, correlation doesn't indicate which direction that causality might happen. So jumping back again to the body dissatisfaction example, from other research, from experimental designs where we can assume that there is some kind of causality between body dissatisfaction and eating disorder pathology, we don't know which is causing which. So we don't know if body dissatisfaction is causing eating disorders, or if people that have eating disorders then develop body dissatisfaction. All right, so there's also factor analysis in addition to the Pearson coefficient. Factor analysis is something we touched on in personality assessment. It's a method in statistics for examining interrelationships among a number of variables at the same time. So in correlation, we just had two variables, and we're looking at the association between those two variables. In factor analysis, we can look at lots of different variables and kind of figure out if there are like underlying associations between groups of those variables. Two more common research designs are cross-sectional versus longitudinal approaches. So cross-sectional design compares different groups of people at one point in time. It is correlational, and there's no experimental manipulation. You just observe differences between two groups. So you might have those anxiety and control scores on men and women, and you might look at if men and women differ on measures of anxiety and control. This can be done retrospectively. So you can look at data that was collected a long time ago, like archival data, we call it. An example from Jamal's work, you can look at individuals with and without eating disorders and ask them about body dissatisfaction. And this might show you if there's higher body dissatisfaction in people with eating disorders. In a longitudinal design, you're looking at individuals or a group of individuals at more than one point in time. So it's research that is designed to look at changes over time in your groups. So again, an example from Jamal's work, assessing how an individual's body dissatisfaction and self-esteem, as well as eating behaviors, might change over time. And you can look at how those factors are differentially associated at those different time points. There are definitely challenges to longitudinal work. So most research questions are more interesting if you can look at them longitudinally, especially in clinical psychology. People change so much over time, and often the research we have is just at one time point. They just come into the clinic or the research lab once, and we study them at that point. And they move on, and most of that is because of money constraints. And as well, time constraints. Usually we have to complete research projects within a given amount of time, but longitudinal design is kind of what most people wish they could have in their research if time and money allowed. Another difficulty of longitudinal work is that often participants won't come back. So you might lose contact with participants, they may change their phone number, move away, or no longer be interested in the study. So longitudinal design is associated with a lot of challenges, especially resource-related challenges, but it's a really strong type of research design. And then the experimental method, which is what most people think about when they're thinking about research. Most people think of dependent and independent variables, and you're manipulating one of the variables and seeing how it affects another one. So experimental design is where we can determine cause and effect relationships, or at least it's appropriate to interpret the results as cause and effect. Because you have your independent variable, which you're manipulating or controlling, and your dependent variable, which you're measuring, which you think is impacted by your manipulation of the independent variable. Within an experimental design, the experimental group is the one that receives the treatment or condition of interest. So in the second example about the exposure therapy, you might have two groups, the people who are receiving exposure therapy and people who are not receiving exposure therapy, and the people receiving exposure therapy would be the experimental group, and then the other group would be the control group, the one that doesn't receive the treatment or condition of interest, and you compare the two groups to see if the intervention or treatment is working. Internal validity is the extent to which the change in the dependent variable is attributable to the manipulation of the independent variable. So this is essentially saying the extent to which your experimental design is measuring what it's hoping to measure. And external validity is the extent to which the results are generalizable. So if you do find a change in somebody's eating behaviors after exposure therapy, maybe you find people are less likely to avoid desserts after this exposure therapy to like high calorie food. The external validity would be the extent to which this generalizes to maybe men. So maybe you did the study with only women, and if it generalizes to men and to people of different, living in different areas of the world, people of different cultural groups, it would have high external validity. A confound is an extra variable within an experiment that's not controlled for and that might be affecting your independent or your dependent variable. So an example of a confound is like expectation. So somebody who is enrolled in this clinical trial of whether exposure therapy works for eating disorders, if an individual who's in the experimental condition who's receiving the exposure therapy expects the therapy to work, this would be a confound because it's not the therapy itself or the exposure itself that is necessarily helping the person improve. It might be this expectation that they're going to improve. So that would be considered a confound. When expectation is in the participant, this is like a placebo effect, just like in medication trials where if somebody expects a medication to work, this can actually help the medication to work, or they might feel better even if the medication isn't really doing its job. As well, there can be expectation from the investigator. So if the person running the study expects the therapy to work, then they may even inadvertently be perceiving the people in the treatment condition as getting better. And so one way that this is controlled for is called the double-blind procedure, where the participant in the study doesn't know which condition they're in. And so, for example, they're not told much about the therapy. They're not told that this exposure therapy is necessarily supposed to help them, or that they don't receive much information about how this therapy is supposed to help them. And the person making the assessments in the end, the person assessing whether or not the treatment was effective should be someone from the outside. So they might be measuring like eating behavior in people in both the experimental and the control groups, and this could be someone from the outside who doesn't know who was in the experimental condition and who was in the control condition. Random assignment is one way that people control for confounds. So in random assignment, participants are placed randomly into the experimental and control groups rather than self-selecting. So you, in the exposure therapy study, you wouldn't want participants to decide themselves which group they're going into, because the more motivated individuals might go into the exposure therapy group, might choose to go into the exposure therapy group. And that could be a confound. Motivation could be a confound. So yeah, random assignment can be a really important way to ensure that there aren't research participant characteristics that are creating those groups. Increasing the sample size is a really important way statistically to reduce confounds. Higher sample size can kind of dilute individual characteristics that might be confounding your results. Another really important and prevalent way to try to control for confounds and extraneous variables is to match the experimental and control groups on different characteristics such as age, baseline levels of psychopathology, so making sure that the people are sort of equally sick that go into each condition, for lack of a better way of saying it. You want to probably make sure that there's equal numbers of different genders in both groups so that you're not getting gender effects. Socioeconomic status and education, other factors that could influence people's performance or people's general clinical presentation, you would want to control for in the experimental and control groups. So jumping back to the example of the BMI label study that we first talked about, I want to give a little bit more detail on the research design that Jamal and his colleagues decided on. The procedure was participants came into the lab, the research assistant measured their height and weight, and participants were blind to these measurements. The research assistant went into another room to enter the height and weight into a computer program. And then this computer program importantly randomly assigned the participant either an accurate or inaccurate BMI weight label. So for example, a normal weight participant was equally likely to get the accurate normal weight label or the overweight label. And the research assistant then selected the packet of measures with the appropriate cover letter. And so the cover letter looks something like this. Saying like the researchers have measured your height and weight to calculate your BMI, and your BMI status is overweight. And then having been given this label, the individual was asked to fill out questionnaires, and everybody filled out the same questionnaires. So importantly, this packet was given to a second research assistant to maintain blindness. So the second research assistant was not aware whether this was an accurate or inaccurate BMI label, and the second research assistant gave the participant a space, like a segregated space where they could fill out the packet, and the packet included questionnaires that measured self-perception of body satisfaction, and prospective healthy or unhealthy dieting behaviors, meaning whether the participant planned to diet in the future. And so what was being manipulated here was whether or not the participant was given an accurate BMI label. So a participant might have a certain level of body satisfaction or body self-perception, and Jamal and his colleagues wanted to know whether labeling, giving a BMI label, whether correct or incorrect, would affect the responses in these questionnaires. So these are just a description of the participants. So there were individuals who were both overweight and normal weight, and then they were given these different labels, but notice that the means are pretty close. So people were relatively close in terms of their actual weights. And then these are the really interesting results. So in these black bars, you see people who were actually a normal weight, and in the black bars, the one on the left denotes people who were a normal weight and were given the correct BMI label, normal weight, and then people who were over a normal weight but given the overweight BMI label. And you see a slight reduction in body image. So people who received this erroneous overweight label did seem to experience a reduction in their body image based on that label. And then in the overweight category, people who were given the normal weight label, so who were maybe technically overweight based on our based on BMI labels. They had a higher level of body image satisfaction, so same level of body image. I'm sorry, not body image satisfaction, it was just like their general body image, same level as people who were a normal weight and given the normal weight BMI label. And then people who were overweight and given the correct overweight BMI label, there was the lowest level of body image in those individuals. Interestingly, and I think this is good news, there weren't differences found in whether the participants expected to engage in unhealthy eating behaviors, interestingly also no differences were found in whether participants expected to engage in healthy weight loss behaviors. But I think this is kind of important, that just based on BMI labels, people didn't feel like they necessarily needed to change their behavior in the future, which I think is good news based on the fact that BMI labels are not necessarily associated with actual health. Okay, so that was just an example of how the experimental design could be used in a clinical setting. And I think Jamal and his colleagues did a great job with that study, and they were careful about randomizing and matching and keeping both participants and some experimenters blind to the experimental condition. So some more information about the experimental method. There are between groups designs and within groups designs within experimental methods. So in a between group design, you compare the results between groups of participants, the experimental group and control group. So this is like Jamal's study. And in the within group design, you focus on the results of individual subjects. So this is often in a longitudinal design, you might be looking at within a single group of subjects, changes over time or changes over condition. And one benefit of a within group design is you need fewer subjects because you have many data points on those subjects. So the BMI label study used a between groups design. Within groups design could have been used. So if they had restructured the experiment to look at people maybe like before and after they were given the BMI label, and not kind of had these two groups that were given the erroneous and the correct BMI label, but rather just looked at individuals before and after being given a BMI label, that would have been one way to change it to a within group design. Single case design is actually a type of experimental design that occurs within one individual. So people sometimes do this on a therapy client who they want to test a treatment on an individual therapy client. And so you would be looking at a participant or a client's change in time in response to different conditions, different treatment conditions. So a common single case design is the ABAB design. And this observes systematic changes in the participants' behavior in the treatment and no treatment conditions, and they alternate. So A would be no treatment, B is treatment, and then you go back to the no treatment phase and then the treatment phase. So it's like a baseline intervention, returning to baseline, and intervention phases. And this is an example of an ABAB design. So if you have a child, so this is often used in behavioral interventions for children, especially people with autism. Behavioral interventions are common for especially young people with autism, and in the ABAB design you can kind of see if these behavioral interventions are changing the individual's behavior. So in this example we have Thomas, and the intervention is the social story intervention, and the target behavior is improving sitting in circle time. So we want this kid to sit in circle time. The intervention we're using is the social story intervention. So in the we're looking at the percentage of the study behavior, percentage of time that he's sitting appropriately during circle time, and looking at that in the treatment and the baseline conditions. And so you can see from the graph that it seemed to work for Thomas. At baseline, he wasn't sitting very much. And then in this like reinforcement 1 phase, the sitting behavior is more frequent. And then you would go back. So the reversal is going back to this baseline condition of not using the intervention, and the sitting behavior decreases. And then in reintroducing the intervention, sitting behavior again increases. And you can see how this is kind of a compelling way to demonstrate that an intervention is working in one individual. So it ABAB design evaluates the effectiveness of treatment. Again, reversal is the withdrawal of treatment, sort of like returning to like a baseline. There can be issues with the ethics of withdrawing treatment. So if a treatment seems to be working, it does seem, it can be seen as unethical to take that treatment away. There's also the issue that the positive effects of the treatment may continue despite withdrawing the treatment. So it can appear that, or it can be the case that in that first B phase, the treatment, improves Thomas's sitting behavior, and when the treatment is taken away, there are some kind of like after effects where Thomas is still exhibiting good treatment behavior, and I think we saw that a little bit. His sitting behavior in the second A phase was still a little bit higher than the first A phase. And of course, ABAB design has limited external validity. So we know that this intervention works with Thomas. We don't know if it works with another kid. So there are a couple other research designs that were mentioned in the textbook that I'm not going to cover in the lecture, because I think this was a pretty dense lecture and a pretty dense textbook chapter in general, especially for those of you who may not have taken research methods or psychology research methods. So I'd like you to read over that material, the other research designs in the book, but don't stress too much about the details, and I'm also not going to test you over that material. So I'm going to test you over the material that has been included in this lecture. The last thing I want to talk about in terms of clinical psychology research is research in ethics. Ethics is an extremely important aspect of doing research, especially with clinical populations. These people are often at more risk for exploitation, and the results of research can impact the treatment of people with mental illnesses. So it's incredibly important to take ethical considerations into account. And entire courses are taught on the ethics of research in clinical psychology. So this is a really big topic that I'm trying to cover in one slide, but I'll give you the basics. So the American Psychology Association has some standards. The main points are that informed consent must always be attained from participants in a research study. So a researcher needs to tell the participant, and we usually give them like a sheet, a piece of paper that they read through all the risks and potential risks and benefits of the study, and we get written consent that they are knowingly participating in this research. Confidentiality of data is incredibly important. Typically, researchers will de-identify data, meaning instead of using somebody's name, you use a number like 1001 to identify a research subject, so that their data, especially sensitive data like diagnoses, etc., are not linked to the person's name. Deception is sometimes necessary within a particular study design. For example, in Jamal's study of BMI labels, some subjects were deceived into believing that they were given a BMI label that was actually not true. In the case of deception, it's important to debrief individuals after the study, or tell individuals after the study that information they were given was incorrect, and also provide a rationale for why they were deceived in the study, so people don't feel that they were just being jerked around. They understand that deception was necessary to obtain the research results. Fraudulent data, I think it goes without saying that under no circumstance should data be altered in any way. Extremely important to maintain public trust and to make sure that that the data and the information, or the research conclusions and the information that's being disseminated to the public and to other people in the field is accurate. So kind of under fraudulent data, or maybe akin to fraudulent data, is the idea of interpreting your results in a responsible way, not over-interpreting the results of the research, acknowledging limitations and drawbacks of the research, so that the information being drawn from the study is accurate and not overblown.